IV bag, another delivery. If there's anything I forgot on this list here. Going to report any adverse effects and complications to the healthcare provider immediately. The Q-Pump is another delivery that, it's a new method, not so new anymore, but it administers local anesthetics right to the nerve at the surgical site. Since it is inserted in surgery, patients remove it at home. They need to report if they have fever, chills, sweats, difficulty breathing, redness, warmth, discharge from the catheter site, swelling, bruising, dizziness, lightheaded, blurred vision, numbness, drowsiness, or confusion. If a hospitalized patient has had surgery, what's the most effective schedule for administering pain medication? Around the clock. Around the clock. Also have pain medication available for breakthrough pain. Anytime you're dealing with pain, until you get that dosage right, or even when you may have, I know in hospice care lots of times, we would have a patient stabilized for a month, and all of a sudden, it didn't work anymore, and we had to make adjustments. So, just because you hit that sweet spot, doesn't mean that that sweet spot's always gonna work. So you always have to be assessing, and rather than leaving them in pain to say, oh, I wonder why you're in pain, and you can't have anything for 2 hours or 3 hours, you have something for breakthrough pain. No one should be uncomfortable and in pain. No one. Have them, encourage them to report if they're having breakthrough pain. Give them control, that they feel like you believe them, you're on their team, you're working for them. Very important that they understand, that they know they can depend and trust you. That in and of itself will bring down pain level a point or so, just the control and the trust. Who is best qualified to rate a patient's pain? The patient. They are to be believed, and it is to be acted upon. Why are the elderly at increased risk for experiencing pain? Adverse effects of pain medicine, I'm sorry. Because they're old people, right? No. It's not normal to have pain, but things that are normal in age process make pain management a little different with the older population. Their liver and their renal organs don't work like they used to. So medication, the clearing it out, the excretion of it is prolonged, so that prolongs it being in their system longer. It sets them up for side effects because it's not getting cleared out like normally should be. A little slower. It still gets there, but it's slower. Also, especially if they've had a lot of medications in the past, they may have a tolerance for the medications. They may have a decreased tolerance for the pain though. So they're gonna have more side effects because they have polypharmacy, correct? They have body system issues, correct? So all of these things comes together in a recipe that sets them up for adverse effects. If an elderly person is experiencing increased side effects from pain medication, how can we fix it? Smaller doses, because that smaller dose is going to be in there longer if they're not clearing it out. So smaller doses, longer intervals between, because if they are getting it every 2 hours and it's staying in their body for 4 hours, then they're just building up to get the side effects. So it may be we give them a smaller dose every 4 hours instead of every 2 hours, or whatever. We adjust things to try to meet their needs. Don't stop it. They still have pain. So we still need to treat the pain. We just got to figure out how best to treat it without hurting the patient and giving them side effects that they don't need, because side effects they don't need cause falls, cause all kinds of issues, and you start down that road of a fall, broken hip, tissue integrity problems, clotting problems, all that just adds to their woes. Avoid the use of Demerol and Valium in the older population due to seizures and increased risk for sedation. Non-pharmacological measures go a long way in the elderly patient. Sitting down and having a conversation with them and making them feel valued will go a very long way. Getting in their world. Post-op patient, getting their opioid via pump. What's the benefits of a pump? Gives them what? They have control, right? Gives them control. They don't have to wait. If you know you have to wait for something that you want, what does that do to your mind? You get focused on it, right? I can't have pain medicine for 2 hours. Or I gotta wait till that nurse does this, and gets back to me, right? So having that control, they don't have to wait. And in that way, they don't have to wonder when they're gonna get back to me, how bad is my pain gonna be before they ever get around to getting back to me. Those thoughts start, just revving people up. Oh, I gotta wait till that nurse gets back from lunch, or till she's finished here. Well, what will my pain be then? And then if my pain gets out of control, is it gonna get controlled quickly again? They think about these things because they're uncomfortable. So pain counselor, it gives them control. You use less because they're in control, less amount, less side effects, more pain control. If they're pushing the button only, and they're even if they're pushing it like a call valve, the pump itself has safeties on it, so that they're not going to over-medicate themselves. They're not going to have the side effects, even if they may feel that they're, oh man, I'm loading up on the medicine. Well, there's safety issues, there's safety sets in there that keeps that from happening, so they're not going to get over sedated, and they shouldn't get to that respiratory depression, especially if they're being monitored. Now, the caveat on that is if they are receiving a basal rate and they're getting sedated, you need to be calling the healthcare provider. That's huge, because that basal rate's gonna keep going every hour, no matter what they're doing with their pump, their little button. But this also helps them with that control, the better pain medicine, helps them sleep better, helps them be in pain control so they can eat better. And if you're sleeping and getting good nutrition and getting good hydration, what usually happens to our bodies? They heal, don't they? So all of that works together. What strategies have you seen or used to promote comfort? What are some things you guys have done or seen that's been helpful? Positioning, heat and cold. I know when I used to do long-term when I was CNA, and I had a few patients that just loved to get a back rub. Oh, they please just rub my back, rub my shoulder here. So that personal touch, don't ever forget as we become nurses that are more technology related, my heart breaks for people that are in the hospital right now because they already have so many obstacles to overcome with COVID. And I know in class here, it's very difficult for me because I can't recognize you guys. I mean, half your face is covered. How am I gonna get to know somebody through their eyeballs, right? So whenever our patients see us, whether you know it or not, they're looking in your face before COVID. Whenever you had a patient and you introduced yourself, that patient was checking you out. Trust me, they're looking at your face. Is this person showing, are they smiling? Do they seem kind? What do their eyes say? People were looking. But now, they got half that removed, right? They don't get to see this. They don't get to see if you're smiling. They don't get to see if your whole face that you are a caring person or that you're communicating that. So they're already at a disadvantage of trusting you, right? And you're at a disadvantage because what does a patient's face tell you? And if you are in the community situations or in an ER and everybody's wearing a mask, you've already missed out half your data of what you're assessing because you can't see, correct? So we are all operating from disadvantage and all very easy right now to miscommunicate something. Lots of miscommunication just by people assuming stuff on half data, because we're all got half data right now. Any questions? I will give you guys a 10-minute run to the restroom break, and then we'll